And while we're waiting for others to join, you might see a pop-up indicating recording and transcription is occurring. We are going to record this meeting. So this will be available once the state would post it to the web page, the rate reform web page. And we'll give it just another minute to see if anybody else will join us, and we will get started. For those of you that just joined, we're just waiting another minute to see if anybody else is going to be joining us. I just saw something come through the chat. Is there an echo? Does anybody else hear an echo? I see a lot of people responding in the chat, no echo. So maybe if you go out of the meeting and come back, sometimes that does, for whatever reason, help clear speaker or Teams kind of issues. And the chat is working this morning. See that? So, okay, we will go ahead and get started. I want to thank everybody for joining so early this morning. 9 a.m. meetings sometimes are difficult, but sometimes easy. So thank you, everybody. We are here today to talk about the HCBS rate determination interested parties engagement session. And specifically, we are looking at care coordination, section of policy 12, 19, and 96. Next slide, please. So with that being said, we're going to, again, focus on activities and codes related to care coordination services as defined on this slide, which specifically fall under policy sections 12, 19, and 96. So care coordination services are those services covered and provided by a care coordinator who is employed or contracted by the service coordination agency to help the member access the services in the plan of care as authorized by the department or its authorized entities. The purpose of the care coordination services is to assist members in receiving appropriate, effective, and efficient services which allow them to retain or achieve the maximum amount of independence possible and desired. Care coordination services are designed to assist the member in identifying immediate and long-term needs so that the member is offered choices in service delivery based on his or her needs, preferences, and goals. Care coordination services assist with locating service providers, overseeing the appropriateness of the plan of care by regularly obtaining member feedback and monitoring the member's health status. We understand there may be providers that provide care coordination under other sections such as 18 and 20, but those services are more aligned with targeted case management and being evaluated in another rate determination process conducted by Burns. For more information on other projects or sections of policies being reviewed, please see the rate reform website. And we will also post in the chat the rate reform website link as well. And section 13 also is targeted case management is not necessarily included in today's focus. Next slide, please. So with that being said, listed here are the care coordination codes identified for this particular rate determination project. There are 3 codes total for these particular sections of policy 12, 19, and 96. They're G9001, G9002, and T2022. Next slide, please. So for our agenda during the next 60 minutes, we'll quickly review the rate determination process, project overview, goals, and activities, and then get into the questions and opportunities for discussion and feedback with additional questions that you may have that we've not addressed yet or wrap up. Next slide, please. For our introductions, I'll quickly introduce some of the PCG team. We are a public consulting group. We're working with the state of Maine on this particular project for the home and community-based services. Myself, my name is Rhonda Kern-Stralzer. I'm a senior advisor of behavioral health here at Public Consulting Group and lead the interested parties sessions. Emma Feinstein is actually on our call as well. She's a project lead and senior consultant. Maddie Wall is a business analyst. She's also on the call. I also saw Jonathan Sauershow. He is on the call as well from Public Consulting Group. We do have some of the Maiden Care team on the call today. Does someone want to start off by introducing the team?
I can go first. Hi, everyone. Good morning. Thanks for joining today. My name is Kristen Merrill. I am a senior policy manager with the Office of Maine Care Services in the policy unit. I am leading this effort from the Maine Care perspective. I'm also joined by a couple of additional folks on our policy team, Tom Leet, who is a manager in our policy unit, as well as Heather Bingalis, who is a policy writer, and Megan Brooks, who is a policy writer. I'm going to pass it over to Jessica.
Hey, good morning, everyone. I'm Jessica Levesque. I am a project manager on the rate reform team under rate setting, and I'm joined today on my team with Jennifer Morse, who's also a project lead, and Amanda Lee, who does our notices and does a lot of our communication and email for us. I'm going to pass it over to Nicole.
Thanks, Jessica. Hi, my name is Nicole Rooney. I'm a program manager for the Office of Aging and Disability Services, Long-Term Services and Supports Unit. We serve as the operating agency on behalf of the Office of Maine Care Services and manage the day-to-day operations of sections 19, 96, and 12, which we'll be discussing here today. And I am joined by my colleagues, Karen Mason, who is the Associate Director for Aging and LTSS, and Allison Toomey, who is the Manager of Community LTSS programs here at Oates. Thank you.
Back to you, Rhonda.
Thank you. All right, next slide, please. So the next thing we're going to talk about is the rate determination process overview. Some of you may have been on the kickoff call that we did at the end of August, and this is just a few slides I just want to kind of highlight here in this presentation before we get started. So while this meeting focuses on the feedback from participants regarding care coordination, I want to highlight that process. The rate reform process sets the schedule for regular rate reviews, benchmarkings, also creates a transparent process and includes technical advisory and comments. So those highlighted pieces there. Next slide, please. So within that process, the steps for the rate determination process include a kickoff call, which was held 8/28/24. That also can be found on the rate reform website. The public forums for feedback, as well as included in this official written comment period, department review, and final rate determination, which should be around April of 2025. So that's when you should expect something after that time. that would be coming out. So during this process, PCG will hold and conduct interested party sessions, collect data and complete different pieces of analysis. We'll develop a rate model, as well as draft rates, make presentations for comments, finalize rates, and also publish and make final recommendations for main care to consider for rule proposals and adoptions. Also, I want to review a few items from an interested parties engagement standpoint. These meetings are the first general meetings to start gathering information, and we anticipate further meetings in the future with additional focus items and a survey to gather additional feedback. In addition, we also have an email set up that you're welcome to send information, questions, or comments to, and we can put that in the chat, and then it will also be displayed at the end of this presentation. Next slide, please. So following the established requirements for rate determination process, this project focused on home and community-based services, including all these following sections, which are assistive technology devices and services, care coordination, which today's meeting is specifically is the focus of, under section policy 12, 19, and 96, clinical services, supportive skill building, therapeutic interventions, and personal services will be the focus, or personal services as well as part of this project. I do want to note other projects are occurring simultaneously with other partners in main care during the same time frame. So they're also reviewing other sections, payments, rates, and codes. So if you're not seeing a section listed here, please check the rate reform website for other projects that are ongoing. Again, this section will focus on care coordination. However, if you're interested in providing feedback for any other sections or services listed, we're having specific meetings for those that will be upcoming, which are listed on the rate reform website in the kickoff presentation. Emails will go out through the listserv, and we will be putting those dates in the chat as well. Next slide, please. So our project goals out of this, we're going to develop and document appropriate benchmarking, service definitions, rates, coding alignment, engage with interested parties throughout the entire project. We're going to demonstrate the impact of changes to rates or service definitions. So if there would be any things that are changing. And then we're going to ensure alignment to state and federal reimbursement requirements. So those are the main goals that we will hit throughout this project and certainly by the end of this project. Next slide, please. This just quickly kind of shows what's been happening activity-wise with us here at PCG on behind the scenes, and also with main care and what's kind of been going on. So currently we have identified codes and rates for each section, and that list can be found on the rate reform link. We have been analyzing codes, identifying benchmarks, and for services without those benchmarks, we're creating benchmarks with input from providers, certainly creating assumptions based on best practices and national trends, things like that, other payers. I see that they are posting some of the links in the chat right now. So you can see the entire list of the codes, as well as this link on here. If you would need to go back to the presentation, the link is on here as well. When I said earlier that we were going to be having additional meetings and survey, this is the reason why, is because we, in creating benchmarks for rates or codes that currently maybe don't cross a line with Medicare, for an example, or another benchmark, we will gather information and assist with creating benchmarks based on provider feedback, some assumptions, best practices, national trends. And again, throughout this whole entire project, there will be different interested parties, engagements, or information sessions as we continue throughout this process. Next slide, please. So we're posting this again for the care coordination codes that we've identified for this rate determination project. And before we start the questions, I again want to remind everybody of the current care coordination codes that we have identified with the assistance of Maine Care, which is displayed here. These three codes specifically relate to section of policy 12, 19, and 96. So when thinking about these questions and providing answers or feedback, please keep these codes in mind, which are the G9001, G9002, and T2022. So with that being said, we'll go to our next slide, please, and we'll start with the question part and feedback. During this process, please feel free to come off mute or raise your hand. We can call on you. You can also put things in the chat as well during this time. And so with that said, I'll start with our first question.
Rhonda,
Yeah.
before you start, I just want to say that if anybody is on a keypad, on a phone, they would press *9 if they have a question. Thank you.
Thank you, Jessica. What concerns do you have about this rate determination process that you would like the team to be aware of regarding care coordination?
Hi, this is Pete Plummer from Woodford's. I'll start off with a question that kick us off, I guess.
Sure.
The rate determination, is a process that has a timeline associated with it, and that's great. The rulemaking of those, I don't see a timeline related to that, and so is there a timeline with that so the rules will kind of tied to the rate determination so that they're kind of together, the rate, so we know what we need to do, for the rate as far as having the rate calculation also?
Thanks for the question, Pete. So just from a process perspective, the rulemaking would follow the rate determination outcome. It wouldn't happen simultaneously.
So just kind of because this happened in another program that we had, it was kind of hard, to provide the service without a rule. And it just makes it hard for providers. So this is just my opinion, I guess, to provide, to agree to a rate when they don't know what they're kind of agreeing to, in essence. Does that make sense?
It does, yeah. Thank you. And I think we'll document that as a current concern, as you mentioned. I think essentially what the department would be operating on is having to finalize the determination before implementing any requirements within our rules. So we do have to go through the determination process, identify, and then identify a date to implement, any changes in the future, and then be able to codify that through rule. But point is very well taken about being able to understand and comply with any of the requirements associated with the changes that are being made through this process. So we'll definitely document that. Thank you.
Great, thank you.
Thank you, Pete, for being the first one to speak up and also provide a question and some feedback. Sometimes that's hard, so I'm thank you for getting us kicked off there. Are there other concerns or even questions about this rate determination process that, again, you would like the team to be aware of regarding care coordination? Oh, Betsy, go ahead.
Thank you. I think, timeliness is, I would echo timeliness as like the Section 96 rate structure is doesn't adequately cover anywhere near the cost. And so timeliness is really relevant to us in terms of that being for us the most priorities section of the rules. I don't know if you're going to take these in any kind of order or if you're just going to lump them all and do them all together at one time, because there are disparities in terms of how the rate structure is done. Some are done by minutes, some are done by per member per month. And has there been any determination that all of these would be one way or the other?
So I think there's a couple of things I heard in there. One being timeliness and getting the rule eventually, it sounds like finalized and codified to where it's applicable into everyday real world use. And then the other thing is, has there been any determination yet? Was that kind of the second part, was my understanding?
Yeah, so which way is it going to be, has there been a determination that we're going to move all of these to PM or, care coordination is not case management. It's a very different animal. And I think sometimes putting it into minutes, frankly, doesn't work. So, it would be great if everything were uniform so that there was an easier way of being able to know whether programs work financially or not.
So there's been no determinations as of yet. So to speak just quickly about a little bit about our process, we've identified those codes. We are then looking at, requirements, rules, things like that. Looking then at clinically, like how does this play, what does this look like maybe in the real world? Also, looking at things like Medicare, for an example, and how do they do it, or other different types of payers. So there's a whole process that we do go through, as well as getting feedback from, like you, as well as others that are interested in this, to start doing and looking at the potential current payments and rates and how things work. And then, what does that look like in the future? We're not there yet. That is part of this process. We are going to look at all of these codes, and then try to figure out what is the best approach going forward. And that will be the final report that we will give to the state at the end of this project.
Okay, thank you. And if I could ask one more question, will you be looking to the providers who are doing this work right now to help by completing any kind of a survey or any kind of a financial review of what the actual real costs are, et cetera, et cetera? Thank you.
Yeah, absolutely. So yes, we will have some additional focused meetings in the future, specifically like when we start making recommendations or looking at maybe ways to change codes or something. We will work with the state on that to get their feedback, and then we'll take it to providers, as well as we will also have a survey to start gathering some of that financial information as well, and that will be part of this process as well before the ultimate final determination would be made. Does that answer your question, Betsy? Oh, I see.
It does.
Thank you.
Thank you.
Okay, you're welcome. Thank you for asking those questions, because those are really good questions as well, and things that we understand impact providers. So, are there other concerns about the rate determination process that you would like us to be aware of, or again, a question regarding care coordination? And we can come back, or it may come up in another question that we have, which is okay. We will document these things as well. And with that being said, we can go to the next question. But like I said, if we need to come back, or if something pop up, that's fine. The next question is, are there specific codes or rates for this rate determination process where you think changes need to occur for care coordination and why? Betsy, you kind of already hit on this briefly. I don't know if you would like to speak about it a little bit more here and talk to us a little bit about those specific codes or rates or areas that you were talking about.
I'm happy to try to do that. I know we're talking about a number of different parts of the sections. We only do section 96 and section 19 in our organization. I'm with Seniors Plus. We, under section 19, we're paid a per member per month fee for the work we do on care coordination, which works, I think, pretty well, quite frankly. I think that seems to be a really good structure. Under 96, we're paid by the minute. That doesn't work, that structure. That I would, again, I think if it was if we weren't subject to the rounding rule, I think that's an issue as well. That it just is, the type of work is not like a 50-minute hour. It's intermittent work. It's very small doses of time. And I think for me, we need to understand the work in order to understand what the rate structure should be, I guess, and that's just my thinking. Thanks.
Thank you, Betsy. That does give us some additional insight between those two sections of policy. So thank you for that, as well as kind of that rate structure. So thank you. Are there other specific codes or rates for this rate determination process that anybody else would like to speak about directly? Please feel free to put it in the chat or, certainly raise your hand. We would love to hear your feedback. Okay, with that, we will go to the next question. And again, like I said, we can come back if need be. Next question, are there gaps in existing payment methodologies for this rate determination process to highlight for our team regarding care coordination? And I think one's already been brought up regarding the per member payment fee versus by minute. Are there other things that anybody would like to bring up or share or identify for our team regarding the payment and the current methodologies for the rate determination process? We will give it a few minutes. Betsy, can I ask one question about the rounding rule?
Sure.
You had identified that as subject to that rounding rule. How does that impact the delivery of care or the payment?
Yeah. Prior to the rounding rule going into effect, if we could bill for a unit, if we were able to, if we had done work for more than, I think it was 7.5 minutes, might have been 8, something like that you could bill for a full unit, which was 15 minutes. With the rounding rule, you're billing actually by the minute. So it could be as low as 2 minutes, 1 minute, And if you like call someone and, you know, you're talking to them and they're pretty reticent, like some of us, some of the older Mainers are, that, you know, everything's fine, I don't need anything, thank you very much. So some of our calls could be very short. Other things that happen is we sometimes bundle our work so that we may be calling a provider and talking with them about 3 different clients, because we don't want to make 3 different, you know, we don't need to make 3 different phone calls if we're trying to set up care for people and we know that that provider could potentially take those 3 clients. So we might be talking for 10 or 12 minutes about 3 different clients, and then what do? You split that up among, I mean, so do you see that the sort of methodology doesn't, and this is section 96 I'm talking about specifically, the methodology just doesn't really work for the type of work we do. We try to be effective and efficient, and it sort of works against you, which I think is a problem. Does that answer your question?
Yeah, that's a lot of helpful insight from the practicality of what's occurring
Yeah.
out in the world of practice. So that makes a lot of sense. Thank you for adding that additional insight for us. Does anybody else have any additional comments that they would like to make regarding the current existing payment methodologies to highlight for our team, or add anything else to what Betsy has identified? Okay, with that, we will go on to the next question. What do you think is most valuable for our team to know regarding care coordination for this rate determination process? I think there's some things that's already been identified currently with some of the input that we've just talked about here. One, understanding the practicality and what is actually occurring in the delivery of care model. Is there?
Yeah, I think it's, you know, oh, sorry.
No, go ahead,
That's okay.
Betsy.
Go ahead, Betsy.
Well, I was just gonna say, you know, I just think I like the questions. I think these are important questions, and I think just really, if we can all really come to an understanding of what the work really is and how the work flows, or doesn't, or but in the volume, you know, like for example, in our organization, we're always striving to try to get to caseloads of no more than, believe it or not, 85, and we're often up to 100 cases that staff are carrying, and you know that's not at all like, I'm a social worker by training, so it's not like case management, and where you have a smaller, much more defined, much more intense caseload. And so I think really the value that we can all appreciate, I think, is when we all have an understanding of what the work is. So that's just a comment, not a question, I guess.
No, that's valuable feedback. Betsy, I will tell you, I'm actually a nurse and psych nurse practitioner by trade. So been in leadership and administration. And I understand what you're saying too regarding the you know, how the work and the flow and the volumes and those sort of things are impacting. So I think you bring up a lot of valuable insight for our team. Nicole, do you want to?
I'll piggyback a little bit on what Betsy said. So Betsy is correct when she says care coordination and case management aren't necessarily the same. They're not the same, but they do have common components of them. I think it's important to understand that for care coordination for these sections of policy, we have delegated some authorities that are otherwise managed differently under other programs to our care coordination agencies, such as staffing searches and service authorizations. Those are the tasks that are adding to the volume of work that they're doing, in addition to the monitoring of the health and safety of our clients and monitoring of the care plan, which I think is just slightly different, and it is important because it is different work, and it speaks to why sometimes their workflows are a little bit more stop and go. Betsy gave a great example when they're calling providers. They're not calling on one and then hanging up the phone and calling them back again for another consumer. They're dealing with all three of them when they're on the call. So I would just echo that it's really important to understand that. And I would also say that it's really important to understand the nuances between these three sections of policy. So even though care coordination is a common thread, the requirements of the care coordinator may vary slightly as you look at the sections of policy. Section 19 is a 1915C waiver, so we have a little bit higher threshold of requirements as it relates to our agreement with CMS. So there's a person-centered planning component and all these other requirements that we have that sections 96 and 12 do not have currently. So I just wanted to point that out.
No, perfect. Thank you, Nicole, for adding that as well. Certainly, again, great insight into the care coordination aspect. Betsy, you had mentioned that your caseloads are in reality around 100 versus that 85. Can you talk to us about why that's occurring or how that's impacting either the care delivery, also payment, some of those things?
We have very little control over volume, I think, in terms of referrals incoming. They could come sporadically, or they can come in bursts sometimes. So, you don't really have you don't really have a lot of planful time to staff up, so to speak. And because we work on a fee for service, you can't really have people sitting around waiting for work to come. So it's kind of a little delicate dance you do about, do you have enough staff or not enough staff? Or if someone goes out on medical, you've got to reassign those cases to someone else till the person comes back. So it's a constant, and we all know about staffing challenges we're all having these days in terms of recruitment. I'm sure that's hitting the state and other organizations as well as ours. So we'll work our way down to where we want to be, and then someone will leave, and then the caseloads go up again because it takes that much more time to replace that person. So, we're constantly sort of trying to tweak our model to see if, there are ways that we can work smarter, more efficiently. So it's just those everyday challenges.
Yeah, and that's one of the things that I was wondering too, if staffing and recruitment was an issue. So that was some of that as well. So thank you for providing some additional insight into that. And then if I think the other thing might be valuable for our team at PCG, for some of those that are going to be working on this project, that we need to take back, kind of what's that everyday life for that care coordinator person. I know you talked about phone calls and some of those things and back and forth, but could you also give any insight into that for our team, so we can certainly take that back to them?
I would defer to Tracy Smith, who I know is on this call as well, but a lot of this work is telephonic. But Tracy, do you want to speak to that at all?
Sure. Would you mind repeating the question? I missed the beginning part of that.
No, just kind of talk about that day in life, what the functions, what are the things that those care coordinators do on a daily basis, and what does that look like? Because I think that's important for our team at PCG to understand.
Sure. So I'm kind of thinking, right from the start, the care coordinator would receive what we call a feed, which is an assessment. And they have a 2-day time frame to outreach the client to review that assessment. Part of that process may include reaching out to the physician. It involves coordinating the care plan, so seeking staffing through community providers. And then some of the nuances that get thrown in the mix, and sort of along the lines of what Betsy mentioned, shifting gears constantly, is if a health and welfare issue is uncovered or there is an event that requires additional reporting. Those are extra steps that the care coordinator is taking to complete reporting documents, following up with adult protective as needed through phone calls. And I would say that a significant portion of their time is spent making phone calls with no response. So they're constantly leaving messages for not only the clients, but their family members, physicians, involved providers, and waiting for calls back. So when Betsy talks about, working on multiple cases, that is absolutely the case, because if they receive multiple clients who can be potentially staffed by the same community provider, they're trying to be as efficient as possible by tackling all of those cases and seeking staffing at the same time. So it's really hard to capture accurately the amount of time that is spent on the cases. And if the care coordinator is working on cases across multiple programs, that becomes even more challenging, because 2 are per member per month based, which is section 63 and 19. And then you've got the section 19 based on billable units. So tracking that is administratively burdensome on the staff. So rather than focusing on the the care coordination aspects, they're kind of having to track the amount of time that they're spending with each client, which, as you can imagine, if you're working on multiple programs, that's extremely challenging. They also, some of the things that they participate in that are not included in the billable service for, say, section 19, because it's not that, inclusive package of, no matter how little or how much care coordination is provided, there's that flat rate. It equals out across the board. But for section 96, they're often seeking guidance from their manager on challenging case situations. They're participating in case reviews. They may be expected to attend or gather appeal information. All of that is work that is outside of what we could typically include in the billable time. And we also spend a significant amount of time both on the care coordination side as well as our provider contracts and outreach coordinator, educating main care providers, because that whole enrollment process really leaves a lot of questions on the table for new providers. And unfortunately, the education, the training to get providers to comply with the requirements often falls to the SCAs. I understand they receive training at the state level on how to properly bill for services and how to follow the program regulations. But when it comes to the day-to-day pieces of how do you work with the service coordination agencies, what are those timeframes that are expected? How do you work with clients? And when I say providing education, some of it is really the details of care plans, figuring out time allowances, ADL, IADL tasks, and what does that mean? And then there's also very basic things like educating a provider to have a proper voicemail greeting, so that when clients or care coordinators call, the provider isn't answering the phone with a simple hello, and we have no idea who we've reached. So those are all things that are outside of the day-to-day care coordination, but are our daily reality in addition to what we're already providing under the program rules for the client.
Thank you very much, Tracy, for providing that additional context. I think Betsy had initially kind of brought some of this up. Nicole has helped supplement, but you have certainly helped define that and what that looks like, and again gives us a lot more insight into that kind of day to day. So thank you. I see another Julie. Go ahead.
Hi, thank you for Betsy and Tracy for summing up stuff that is 100% accurate. So I work at Alpha One, one of the other service coordination agencies, and we do cover Section 12, 96, and 19. So just to kind of piggyback on what Tracy was saying, there is a lot of requirements and documentation, paperwork, reporting to ODES that sometimes, we don't get reimbursed for, things like reporting hospitalizations, things like if somebody passes away, there's a lot of communication with providers, there's communication with ODES, there's, documents that we're required to do. So those are all things, or all things that could potentially take quite a bit of time for our care coordinators that we can't, really technically be paid for, but, are part of the process that we are required to follow. So I think it's kind of also looking at those types of things that will be really important, and the nuances between each program and how how they work, those things work.
Thank you very much. Tracy, it looks like, go ahead.
Thank you. Julie just triggered another thought that is sort of outside of care coordination, but Seniors Plus is structured in a way where we also have an administrative team who handles all of the letters, notifications, discharges, health info net exchange, and none of those services are billable. It's sort of administrative aspects. So that's another component that is not built into the current rate.
So what I might term as it's the cost of doing business. It's the things that occur is what I'm hearing, that a lot of times are administrative in the function of what you do to help coordinate care for this individual that you also are doing on a day-to-day basis, but it's not billable currently.
Yeah, so that would apply to Section 96. Betsy mentioned that the current PM structure under Section 19 does work well for all of the components, both care coordination and the administrative pieces, as well as the provider education. So this is sort of additional work that goes into, or it's the same work that goes into these PM programs. It's just not paid for by that overall rate.
Okay. Super helpful to know. Thank you, everybody, for continuing to add to the context here to this discussion and helping our team, again, learn more from that real world aspect. Pete, I believe you are, you're next.
Yes, thank you. The conversations reminded me of something that I typically bring up when it comes to services and what's provided and the definition of really what's covered, what's a billable kind of service and a billable event. And it's not so much with a per month service, it's more, the units billed services. One of the things that care coordinators or case managers do a lot of is rep payee work. And rep payee services are defined as non-billable, and it can take up a lot of time, and a lot of times agencies would do the rep payee work for the people that they have under these services, and it can be quite time consuming at times. And I just ask that when you go through rulemaking that you consider adding rep payee as a billable service. That was my only comment.
So when you say, Pete, let's talk about that just a little bit more to give us context. So I'm familiar with rep payee as in that person would have a payee and would manage all their finances and, make sure their bills are paid and, provide like a weekly allowance, as well as take care of, any of those financial aspects. Is that what you're talking about? Can you
rep
clarify
payee
that?
for the Social Security,
Mhm.
process because we receive the Social Security payments for a good number of consumers and, you know, do all that work, you know, on their behalf. And a good portion of that is non-billable. And I've had that specific, you know, request, you know, a few times. And so I just keep on advocating for it. But you're right, exactly. You know what rep payee is. So thank you.
Yeah, I just wanted to clarify to make sure we're talking about the same thing and also for our team as we go back and look at different things. So appreciate that. And also giving us additional insight into some of that day-to-day piece too.
Yeah, just one more thing on that.
Sure.
Social Security does allow you to bill a dollar amount. I can't remember what it is because we don't do that. I don't think most agencies bill their Social Security recipients to provide that service because, I mean, they're on Social Security, they don't have much money. So we don't do that, and I think that's pretty common. So, and what they pay you doesn't a lot of times isn't enough for the amount of work that you do. But I just wanted to kind of throw that out there too, in case somebody asks a question.
Okay.
But thank you.
Yes. Nicole, I think I'm seeing some things coming through chat. Thank you for that, for providing that list of billable versus non-billable. And then you had also identified that rep payee is not applicable to care coordination services in 129619. Okay.
Correct. We're a different service structure than developmental services. So typically our care coordinators are not acting as rep payee for this
Okay.
population.
Well, thanks. I didn't realize that. I just but thank you. That makes sense.
Okay. So that's another clarification point for us. Perfect. Thank you both for that. And then Michelle, I see in your chat as well. Thank you for that, Michelle. Are there other items or things that you guys would like to bring up that you feel like is most valuable for our team to know regarding care coordination as we continue through this process? Thank you, everybody, for that conversation we've just had. Oh, Nicole, I see you just sent something through in the chat.
I was just going to clarify, there was a comment about that's not included in the rate. What I will say is cost of doing business and kind of those things are included as part of the rate. The problem is our rates haven't been looked at in a very, very long time. So we don't know that those costs have kept pace with the cost of doing business. But I just wanted to make that clarification. It's not that they were omitted when the rates were developed. It's that we just haven't looked at them in a very long time.
That's a great clarification, Nicole. Thank you so much for providing that as well. Okay, well, we will go to do we have one more question? Nope, I think, yes. Okay, last question. Is there any general concern that you would like to make sure our team is aware of regarding care coordination for this rate determination process? Betsy, I see you'd had your hand up probably from the last discussion, and that's fine. Please feel free to go ahead.
Thank you. I was just going to say, though, I think the other part of the problem with the rates, in addition to what Nicole just said, I agree with her. When I first started 15 years ago and we unbundled the rate, they did take into account the cost of doing business. However, the rate structure has changed without that being re-examined. So what used to be a 15-minute billing unit is now a minute-by-minute billing unit for Section 96. So there's been a significant change in the way we bill, and we didn't go back through and do a rate determination on that. Just want to clarify.
Thank you. Thank you so much for adding that. Are there any general concerns that you would like to make sure our team's aware of? I'll give you everybody another minute, or if there's other anything else anybody would like to bring up where we've talked about earlier, please feel free to bring something up if you would like. As we are getting ready to close out, we have about 4 minutes left in our meeting. Please feel free to use that time and bring anything up that you would like our team to be aware of, or something that maybe that we've not talked about already. With that being said, can you go to the next slide, please? This is our project email for communication questions and comments. It is dedicated email. It's main HCBS canc@pcg.com. Emma just put that back in the chat as well. I see that come through. Please feel free to reach out to us that way as well. If you think of something later on. We also, like I said, will be having additional interested party engagement surveys, those sort of things. Our communication will go out through the listserv. And so anytime we have something come up that's specific to care coordination, it will come through there. Please feel free to sign up and be a part of that so we can get additional insight and feedback as we move through this process. Any other questions or items that anybody would like to bring up? Pete, I see that you just said thank you for the opportunity for your discussion. Actually, thank you for joining us and providing insight. We appreciate that. And actually, to everybody on the call, that's something that, we want out of these, and we value what you guys have to say. So we want to make sure that we're able to meet. And again, thank you guys for joining us. Last thing, rate reform website information from this will be posted out there on the rate reform website. So you can go back later on as well and look at that. And I believe we might have put that in the chat already. And then Emma, I don't know if you can go ahead and put that in the chat again, just real quick. So if people can get that. So thank you much for that. Anything else before we close out this meeting? All right. Well, thank you everybody for joining. Thank you for participating. We appreciate everything and all the insight, and we'll certainly take that back with our team and start working on some of the pieces that you guys have discussed and consider those things in what the rate reform. So with that being said, thank you very much. Have a great day, and we'll talk again. Thank you. Bye-bye.